A Kawasaki-like disease called Multisystem Inflammatory Syndrome in children is an emerging complication during the COVID-19 pandemic. I'm joined today by ASN Treasurer Keisha Gibson. Dr. Gibson is Clinical Associate Professor of Medicine and Pediatrics and Chief of Pediatric Nephrology in the Division of Nephrology and Hypertension at the University of North Carolina at Chapel Hill. She is also the Vice Chair of Diversity and Inclusion for the Department of Medicine. Keisha, thank you for joining me today.
Well, thank you for having me.
So what is Kawasaki disease, also known as Kawasaki syndrome?
So Kawasaki disease is actually a pretty rare inflammatory syndrome that many of us in pediatrics have seen, primarily when we're working in general pediatrics. This is classified as a vasculitis, and in kidney land, I think that many of us are more familiar with the vasculitis syndromes that affect small blood vessels like ANCA vasculitis and in IgA vasculitis. But this is a disease that affects medium-sized blood vessels. It's typically really found in children that are less than 5 years of age, so a condition that is found in the very young. We don't understand a lot about what triggers it. There are some theories that potentially there could be some infections that might trigger it in children. There are some other theories that it may be more of an autoimmune process, possibly driven by some kind of autoantibody yet to be identified. But for most children, thankfully, it is a condition that can be successfully treated, usually with some IVIG and aspirin. In its mildest forms, we see this systemic milieu of prolonged fever for more than 5 days, swollen lymph nodes, a rash that can affect the trunk of the body, but in particular, the palms and soles of the hands. After a week or so, we may notice some desquamation of the hands and the feet. And in this worse or more severe forms, affecting the coronary arteries, which can be a very scary sequela. Again, most of these children do recover, but there are some that can certainly experience some chronic long-term damage due to the coronary findings.
And how does multisystem inflammatory syndrome in children differ from Kawasaki disease?
This is a big question that's on many of our minds. I think that the early identification of the similarities between the syndrome is really related to the clinical presentation. These children that are presenting with what we think is this COVID-related multisystem inflammatory disease come in with prolonged fevers, oftentimes skin rashes that appear very similar to what we would expect in a vasculitis type picture. They could have lymphadenopathy, and certainly quite a few of them have presented with hypotension, and we've found some of these coronary artery findings. And so because of that, there obviously is a tendency to draw a lot of similarities between the two conditions. And in the children that have been the most impacted, we certainly are approaching their treatment similarly to how we would a Kawasaki patient with IVIG. There are some children that, of course, are having significant clinical manifestations or are critically ill, and we've had to step up our therapy to more of an to treat them aggressively from an inflammatory standpoint. And some of these children are receiving things like anakinra, which is an interleukin-1 receptor antagonist. But that is really reserved for these, very severe pictures, because again, there's a lot that we don't understand. We certainly see that there is a large percentage of these children that clearly have COVID-19 viral titers that can be measured. There's some that we've been able to demonstrate antibodies, demonstrating that they have had COVID exposure, but there is a percentage of these children that have no evidence of COVID exposure. And so because of that, we are definitely still in an area where there's a lot to be investigated.
So what advice would you have for parents during the current pandemic?
That is really the million-dollar question. At the end of the day, I really encourage the parents that I speak to to trust their internal barometer and their thermometer. We want to make sure that the things that are in our control, we take control. You want to limit your potential exposures. We want you to wear masks and your children to wear masks if you're in public. We want you to follow the CDC guidelines of social distancing. At some point, we're going to have to figure out how to reopen our community as safely as possible, and again, take control of the factors that we can control. At the end of the day, the majority of children that are getting sick from COVID have done well. At this point, children make up about 1 to 5%, depending on whatever series you look at, of those that are testing positive for COVID-19. We really want to look at that data with the appropriate lens, however, because we don't know what the denominator is. There's a lot of testing that has not been done. And really and truly, the children that are getting tested are the ones that are presenting with symptoms. And by and large, a lot of children don't have symptoms, which also speaks to the importance of making sure that we employ these important protective measures of keeping masks on them, because you don't know if they're infected, and we don't want them bringing that infection home to family members that may be more susceptible to poor outcomes. So at the end of the day, I do think that families need to maintain some vigilance in making sure that they are employing the same protective measures for their children that they would themselves and that they would their elderly family members and friends, and try to decrease even the asymptomatic spread that we're seeing in the community.
So as you kind of think through the next couple of months, starting with this summer into the fall and then the sort of first part of next year, what's your best guess as to how you think COVID-19 will manifest in your patient population of children?
That is a great question. I wish my crystal ball was a little clearer. I do have some concerns. I worry as we move out of the warm months and move into the colder flu and cold season, that we may see an uptick again in the amount of people that are infected. I do worry that as time goes on, there's this desensitization, I think, that happens with individuals, and certainly there are large pockets of our society that just have not been personally impacted by this pandemic, and so sometimes it's hard to maintain the same level of vigilance for a fight when the enemy doesn't really seem to directly be impacting you. I think that as we get closer to most schools opening up, we have some schools that are now trying to figure out because they're on a year-round schedule. And how do you employ social distancing measures when our schools are already overcrowded? I think this is a critically important question, and every state is grappling, and every county for that matter, on how to best deal with this. I think that we have to make the plans to be able to move forward with having the expectation of things getting better and the curve flattening. But we have to be very reasonable in having contingency plans. I think that we have to prepare ourselves for the reality that it may not be that it's safe for all of our children to come back to school, and whether or not it's because of their direct health. Matter of fact, about a week or two ago, there was a study published in Lancet from our pediatric nephrology cohorts around the globe about our experience with COVID in children with kidney transplants and chronic kidney disease. And the good news is that overwhelmingly they did well. When we think about what's happened with some of the people that have had really poor outcomes, and this idea of a revving up of the immune system and sort of an inappropriate hyperimmune response, the answer has been to immunosuppress them. Well, a lot of our children with glomerular diseases or kidney transplants, other diseases that require immunosuppression, could it be, and this is not found, that we don't know whether or not it's helpful. I won't go that far, but what I will say is that the published experience gives us some comfort in seeing that even those kids did well. with handling the virus and avoiding sort of the horrific mortality rates that we've seen.
You said you weren't going to speculate, but I have to ask the question. I mean, any best guess or any other literature that you've seen to try to explain that phenomenon? Because that's really interesting.
No, that is an opportunity, a wide open opportunity for research at this point. All we can give you is what's been observed. And what's been observed is that the individuals that you would worry the most about from an outcome standpoint and related to an infectious disease have not had outcomes that differ from others who are not on immunosuppression. So I think that that's an opportunity for research. And I think that as a pediatrician that's trying to give parents guidance when there's very little evidence-based data to drive what we do, is at least provide them that somewhat of that comfort with knowing that overall, ultimately, children tend to do well. Again, we want to make sure that we're avoiding exposures. We want to limit the spread because even if it doesn't mean that these outcomes, that this exposure is going to directly impact them, we do worry about all the other people that surround them.
Yeah, I'm struck as I'm listening to you and just thinking about schools and family dynamics and sort of the health of your individual children and then the rest of your family, just the sheer number of factors that have to come into consideration here. I guess I'm curious too, just as you think about your patient population and the types of diseases and syndromes that you normally treat, I'm just kind of curious if you could describe for us kind of your typical day or the types of things that you encounter from a clinical perspective.
And I think one of the things that I enjoy the most about being a pediatric nephrologist is really the diversity in the ways that we get to interact with our families and the different conditions that we're helping them to manage. If you were to walk into my clinic and look at the patients I have, you may see a patient who is 8 years old and coming in with high blood pressure without an identifiable cause. We take care of a lot of children that have conditions that many of my adult colleagues are very used to seeing, things like FSGS, IgA nephropathy, and other glomerular disorders. We take care, if you were to look at the majority of children with advanced chronic kidney disease, the majority of these children are those that were born with congenital anomalies of the urinary tract. So a myriad of different things causing problems with urinary obstruction, vesicouretal reflux, renal dysplasia where they develop kidney disease over time. So definitely a wide variety of pathologies that we see in children. And so it is rare for you to find a pediatric nephrologist who doesn't have a wide portfolio and conditions that they've become very comfortable in managing.
It's really interesting. I hadn't thought of it from this perspective before, but as we consider the federal mandate around advancing American kidney health, and a lot of the discussion we're currently having in terms of one of the goals is increasing awareness of kidney diseases and reasserting the value of nephrology. A big piece of that is the relationship between nephrologists, both pediatric and adult nephrologists, and primary care. And I think a lot of the conversation to date has been very monolithic in terms of treating all primary care physicians similarly. And in listening to you, I realize that can't be the case with pediatricians, that it's a very different conversation with pediatrics than it is, say, with internal medicine or family medicine, and sort of how we delineate that. And I'm just curious if you have any advice as to how best to engage with what I'll call general pediatricians around some, the patient population and identifying who's at risk and, the treatment strategies, and then, of course, slowing progression of the disease.
Right. It's definitely a challenge. Ultimately, when we look at just numbers, children make up a fraction right now of individuals that are suffering with advanced kidney disease or even end-stage kidney disease in this country. Having that said, the numbers are certainly growing. So that the way I kind of always keep it in the context for myself, my daughter's, the high school that she was slated to go to has about 3,000 children. And based upon current data, that would mean at least 6 children in that high school are affected with advanced kidney disease or some form of kidney disease. And so when I think about it from that direction, it helps me to understand that that's not zero. And when you start looking at all the high schools and all the schools in the area, you can see how that number quickly grows. And then we think of the number of pediatric nephrologists that are available to help manage those children, and think about how sparse we are throughout the country. I mean, there are 3 countries in the United States right now that have 0 pediatric nephrologists. And so we have to rely on our general pediatric colleagues to help us with the management of these patients, because right now there's just not enough of us to make sure that all these kids are getting their frequent attention that they need. And so I think identifying ways, number one, helping them to make sure that they're helping us identify these children, because oftentimes these diseases, I'm going to take one in particular, like renal dysplasia, is something that can go under the radar for a long time, but there are little clues along the way that there's something going on. The kids aren't growing well. We rely on, for our glomerular diseases, we rely on pediatricians at some interval getting a urinalysis to see if there's blood in the urine or protein in the urine. Right now, the recommendation from the American Pediatric Society is that every child starting at the age of 3 gets a yearly blood pressure measurement. And so it's helping our pediatricians to make sure that they have the support tools, guidance, with everything they need to help us identify these children as early as possible, get the ones that need to see us in as quickly as possible, and then we have to work together to figure out how to continue to manage them. Because, like I said, there are a lot of states that are very sparse when it comes to numbers of pediatric nephrologists, and the average patient seeing a pediatric nephrologist is traveling quite a distance to come see them. And so trying to get that frequent routine care that they need is truly a burden. And so any and every way that we can find a partner with our community pediatricians is going to absolutely be beneficial.
So I'm really struck that there's a huge opportunity in terms of this federal mandate for advancing American kidney health related to both increasing awareness of kidney diseases, but also working directly with pediatrics to identify patients early and intervene and do everything we can to slow progression. Earlier, you had mentioned or referenced one of the other 5 goals of the mandate, which is around enhancing research, discovery, and innovation through NIH, the Kidney Health Initiative, KidneyX, and other payers. So just using COVID-19 as an example, there's a huge opportunity for what I'll call a short-term research agenda, but then also a broader longer-term agenda. What about the other 3 goals? So one of the goals is around shifting the focus from kidney failure to kidney health. Another was this idea of piloting innovative care delivery models through Medicare, which is obviously trickier with this patient population. And then the final goal of the 5 is increasing the rate of transplantation.
No, absolutely. Those are all critically important points of the Kidney Care Initiative. I think of this in a few different pots. One of them that you've already mentioned is payer coverage. Currently, our PPS system fails to really meet what we need as pediatric nephrologists to fully take care of our patients. Part of the reason for that is that we are still in a position where we need appropriate evidence-based studies to help us fully understand the real cost of taking care of a pediatric dialysis patient well. Understanding the extra needs that they have in regards to social work, in regards to just the clinical needs, having pediatric lines, for example, appropriate fluids, dietitian services. Growth is a very important aspect of taking care of our patients. There are lots of different factors that just haven't been formally measured. And so I think that has to be a component that goes into helping us better understand the cost need. We've already talked a little bit about the workforce issues, and you've already highlighted that as well, which I put hand in hand with awareness of just how pervasive kidney disease has been, and this is not just an adult disease. This is a disease that often has childhood origins. And then most importantly, innovation in making sure that, any clinical trial that comes along, this, especially in rare diseases, we need to make sure that the inclusion of children is not an afterthought. We need to make sure that the inclusion of children is the goal with any clinical trial, therapeutics, new equipment, innovations in dialysis. We need to shift our thinking to making sure that inclusion of children is the goal rather than something that we come back to after the trial has ended. And so things that we're seeing through Kidney X has been absolutely instrumental in helping us to move this forward and to sort of move the needle in our thinking within this space.
So you ended on Kidney X, and you anticipated my final question, which is if you were if you had the opportunity to launch, and let's pretend that the money is not an issue, so the money's there, you could launch a prize competition that would benefit children with either kidney disease, kidney failure, or with a kidney transplant. What would your prize competition be? What would the overall sort of goal of the competition be?
A couple of things that come to mind. We need innovation for sure in the dialysis space. We run into lots of issues in trying to adapt equipment that was constructed for large individuals to tiny individuals that are, no more than 7 kilos rather than 70 kilos. We need innovation in how, I'm thinking about my transplant patients, and I think this is something that not only would benefit children, but adults as well. Innovation in how we're delivering our therapeutics. I think that we appropriately focus on sort of the physiology of the pharmaceuticals that we're developing. We appropriately focus on safety and efficacy. What we don't focus on are ways to help improve adherence and ability to tolerate getting the medication in as directed. So thinking about novel ways, patches, thinking about long releasing acting agents, thinking, other ways of delivering therapeutics. I think the diabetes world has done a tremendous job in really prioritizing ways to help with the ease of patients being able to adhere to what's necessary to maintain their health. And I think that in the kidney space, we have opportunity to innovate in that regard.
Well, thanks, Keisha. I really appreciate you taking the time to talk today.
Thank you. Appreciate being here.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.